the story of Jacob and his father-in-law, and they were trying to divide property, and Jacob thought he was clever, and he took pieces of wood and he put it there, and when the animals would go around over it, he would get his... You remember that story? And then when he was sleeping, he was thinking he's a clever man, and the angel of our Lord appeared to him and says, look here, look inside the male animals that are siring them. They are not plain colored, they are actually speckled, they are ring-fenced. As a geneticist, it is a straightforward answer. I said, look at the genotype, don't look at the phenotype. God, he thought he knew what he was doing, but that's a side issue. In terms of assisted reproductive technologies, I believe the issues there can best be looked at from the command that God gave to be fruitful and multiply. God is not a sadist. He cannot ask you to be fruitful and multiply and then withhold the capacity. And therefore, I believe that where we have issues of infertility, God has provided alternatives, methods of support, and where we ought to look at is where it really goes against our Christian standards. For example, when the Bible talks about adultery, which is sex outside the institution of marriage, is adultery the act of sex, or is it the act of insemination of the sperm? Because initially these two were one and the same thing, but now they are separate. They can't be separate. You can have sperm inseminated without the sexual act. Because if adultery, like I choose to believe, is the actual intimate act of sex, then if you can be able to separate them, then you could consider insemination with donor sperm. But if adultery is actual insemination, then insemination with donor sperm would be adultery. What am I saying? I am saying that we are at a position where there are many options of doing something that was fairly straightforward. And as Christians, I think we must know what is available, and we should prayerfully consider the options in view of what the Lord wants us to do. When God asked man to have dominion, ordered him, did not ask him, ordered him to have dominion. If you look at that list, the dominion did not cover other human beings. The dominion covered creation other than other human beings. I choose to believe that God did not ask man to have dominion over other men, because man is made in the image of God, and therefore you cannot have dominion over another person who is created in the image of God like you are. And therefore, any technology that goes into that space, or any act, for example, domestic violence, there is no technology there, that's just violence. It is an attempt to have dominion over another person, and I choose to believe that in that case, you are operating beyond the mandate that God gave.
Prof, before you hand over, please, let me just raise this, perhaps even moving ahead a bit. We've heard of man trying to produce, designer babies. And that's actually your area of genetic engineering, okay? So you have these characteristics, and therefore I will design a baby that, has similar characteristics. Or these ones that are undesirable, so I desire to do away with it and favor those that are desirable. So your take on that?
Actually, assisted reproductive technologies in vitro fertilization. When several embryos are fertilized, it is not necessarily or primarily to choose the best. It is just that this procedure is cumbersome, it is expensive, so when you're doing it, the good doctors here choose to have several embryos. And in many countries, there is laws which regulate how many can be implanted, because we also know that not everything that is implanted will then end up being a baby. But in terms of designer babies, again, it is a question of dominion, I believe, because when we look at breeding, because we're talking about breeding, when we look at breeding, plant and animal breeding has been going on forever. Because man, I believe, has authority to have dominion. But when we come to human breeding, we have a problem. Cloning, animal cloning has been going on, and plant cloning. But when we come to human cloning, then we have a problem there. I believe because of that issue of dominion, and that we are actually getting into a level of tampering with the image of God. Personally, I have no evidence, but I believe that human cloning will not be fulfilled because I do not think God would allow us to tamper with his image that far. I have no evidence, I just think that way.
Okay. Thank you. Mary, you want to add something to cloning or?
If I may, I'll make a comment on genetic engineering in view of the CRISPR technology that has been so prominently in the news. That technology altered germline, had a permanent germline alteration. It caused a huge stir in the international community, demonstrating once again with empirical evidence that human judgment and committees designed to build consensus had problems dealing with accountability. So that's a pretty hot topic, and so I might disagree based on that evidence with whether or not the ability to clone humans exists. I think it exists.
It does, but the actual, I know it exists, and but I say I have no evidence, but I believe God will not allow us to go that far to actually implement it. I think that's too far.
Correct. Yeah.
I would certainly agree that's moving too far. I'd also like to talk about the issue of infertility and pragmatic applications of how to deal with the technology. It's so much cheaper to force or stimulate a woman's ovulation and to harvest a bunch of eggs that people in general, and I don't call them all good doctors, will fertilize many embryos. Embryos freeze and thaw much better than eggs, okay? So if I freeze a bunch of embryos, I can implant the first two, and then if that does not result in an implanted and growing pregnancy, then I've got 2, 4, or 6 more that I got spares that I can use. When that is utilized, people suddenly sometimes have enough babies. So you have a large number of frozen, unchosen, biologic human individuals in special freezer tanks sitting in bottles of liquid nitrogen. And the unfrozen chosen pose a significant moral problem in my perspective. The second thing is, so one pragmatic answer is don't listen to the cost when the doctor says, oh, it's so much cheaper this way. count the number of embryos and say, if I'm not willing to be responsible for each one of these human individuals, and they are biologic human individuals, not everyone calls them persons, okay? Then I think as a Christian, and if you're counseling people in your church, you can draw some boundaries around that. It's been absolutely unsettling, the large number of triplets we've been asked to take care of in our intensive care nursery at Kijabe over the last 12 months. And what's happened is that IVF industry in Nairobi has exploded. Women of financial means are often ones who delayed childbearing for extending their education, all right? And they'll implant 3 embryos because triplets biologically usually have an okay output, and one of them might not implant, so twins is pretty good risk for survival. And they're not willing at that point to do selective reduction, which means an abortion of this one, not that one. And so what's happening pragmatically is that now women are certainly going to deliver prematurely with triplets. We have a huge, your risk of delivering prematurely with twins is also greater. So now you have a risk to all 3 infants, okay? And you have a family that spent all their money getting the technology done from the doctor who did not ask if they had enough money to deliver them. His price or her price was just to get them pregnant. And now the responsibility is gone. So this poses to me a vast area both for counseling from the church, where you can say, if you are going to go to technology, make these demands and be willing to confront the costs so that you are not left with frozen, unchosen human children that you are now responsible for.
Thank you. Mary, before you hand over that, I just want to forcefully pull this panel towards the end. It's not been easy. It's a hot topic that we need to address, yes, but we are just waiting today. So let's move towards the end of life issues. And there are quite a number. I know we've heard about euthanasia that is happening elsewhere, but actually the story now is right here in Kenya. Just a few weeks ago, we saw that in our media, in our papers, written about should we end life and when do we decide to end life. So Mary, yes, I know this is also a favorite area. Perhaps just beginning to help us understand, in your own understanding, when does life end? And how do we make a decision to keep this patient on a machine in ICU, with all the costs and, all the ethical implications? Or when do we decide and say, yeah, this is it. I think we need to pull off the machine.
This is a question that we're having to ask more and more commonly in Kenya as there are more intensive care beds available. Garissa right now Garissa General Hospital has 10 ICU beds. They only have staff to open 4 of them, and they have, I believe, 4 ventilators that will work for premature infants. So we are living in a country where we don't have enough ICU-trained staff to deal with everyone who could benefit. We don't have enough ICU beds to deal with everyone who could benefit. So I want to move this quickly to the most common scenario, which is the issue we're dealing with our parents primarily. What level of intervention makes sense? One of the most radical changes in Kenya over the last 40 years is what I'm seeing and calling the medicalization of death. People used to die at home, right? Now they're more and more and more dying in the hospital. And making a judgment about what is a treatable and reversible condition versus what is something that is progressing for which we may not have any ultimate benefit, okay? And we can answer part of those questions medically. Some of those questions are emotional, okay? My father's had a stroke, okay? He's being spoon-fed. He's coughing and choking. At some point, he's gonna get the normal and natural consequences that come from the coughing and choking, that he's not able to mobilize his secretions. He's gonna get pneumonia. Do I take this one I love to the hospital and say, please put him on a ventilator and see if you can extend his life through this pneumonia? Or do I say, X years ago, this wouldn't have even been an option. We would have given loving care at home. And I think we need to do three things that are useful in the church and as individual families. Number one, and this is really hard, we need to have the discussion. Mom and Dad, what do you want to happen for you? A good life isn't necessarily best measured by the number of days that you live. And so, have the discussion, okay? Talk about it clearly. Number two, push your doctors to talk about what is the medical prognosis, what are the goals of care. And we are not doing enough yet here to train our young physicians on how do we talk about the goals of care. And in addition, we're not yet doing enough to move through good frameworks for addressing all the sets of questions that impact on the ethics and the medical prognosis of care within many of the patients. And that's really the role of growing hospital ethics committees.
Okay, let me bring in Dr. Muhudhia and then Prof here. You know, culture really comes into play here again. For us who are Africans, we rarely talk about death, and bring the discussion and asking, what will you really want in this situation? May be perceived that you have a hand in this death, actually. Africans were meant to live forever. So let me just bring in the two colleagues to help us shed some perspective on that.
Well, as you have said, Africans were meant to live forever, but the longer phase of it is the spiritual life, that our ancestors are alive somewhere watching us and impacting on our lives. So issues of death, that factor comes in the decisions that we make. But having said that, this is a realistic problem that we are facing now. And again, it's as a result of advanced technology. Yes, 30 years ago, we did not have, at least in our country, much the technology to sustain life, okay, in ICUs was limited to very few hospitals, perhaps Kenyatta Hospital, and one or two beds here and there. Now, this technology is now more widely available, so the problem becomes more realistic. And because of the fact that we do not think about issues ahead of time and discuss what has been mentioned here as goals of treatment, that is, when you reach a certain stage of an illness, what is the goal of treatment? Because we know that all of us, eventually, whatever you do, whatever resources you have in this world, we shall all die at a certain time. And you have seen it even in this country, that even people who have all the resources to go anywhere in the world for treatment still end up with death. So at a certain time, we shall end up with death. So we need to address the goals of treatment. There is a certain point in which doctors, when they are truthful with you, will tell you the goal of treatment here is really just prolonging death, just postponing the day of death, which eventually will come. And if decisions are not made at the appropriate time, it will end up impoverishing the family, because they'll use a lot of resources, because end-of-life care, when you are using technology for outcomes that are often the same, that is, they end up in death, are very, very expensive. Very, very expensive. So they impoverish many of us. So it's a difficult area, it's a difficult situation, and again, this is where we need to be talking about it so that our counselors who are in hospital, the Christian counselors, and often pastors are called into hospital to try and help make these decisions. So we need to interrogate this. Now, one of the practices that is common with us is that for several reasons, we prefer to have somebody die in hospital. If we had time, I would discuss the reasons for it. But you know definitely as a family that so-and-so is dying. But you want him to reach and die in hospital. But you know what happens in an emergency when you arrive with somebody who is sick and even gasping, that the emergency team, the first thing is to stabilize and then take to ICU and discuss with you later. Somebody who is almost in the last moments, almost dying, the doctor has no time to sit with you and ask you what is the decision you want to make. He will want to take measures to maintain the breathing, maintain the heartbeat, and then talk later. By that time, the person is in ICU, and decisions become more difficult because it means we now have to terminate, we have to actively stop providing the care that the person has brought. So I do agree that this is a subject that we need to be discussing, and a lot of cultural issues and family issues come into it, and it's very complex in our situation. Thank you.
Okay, thank you, Dr. Muhudhia. As we pass over to Prof, one thing that has helped guide me, I've been in that situation also, where we've had some terminally ill family members, is to make that hard decision. The decision to say that even with continued care, the machine and the medical practice is causing harm than good. You continue treating, they're actually dying anyway. And if you removed your hand, that's the same process. In that, we are considering now, we call it the futility of medical care. As you intervene, actually you're causing more harm than good. And secondly, it's just discussing and making that decision that yes, we need to allow these people proceed to the next stage. Thank you, Prof. Welcome.
Thank you. I think the issue of death, there is a song that is sung, I don't know whether it's in English, but it is in my mother tongue. It says, things of life and death belong to God. I think it summarizes, but also they belong to us because we are here. You see, first of all, there is the legal lacuna, because the definition of death in traditional definition of death is when the heart stops beating, cardiac death. It can also be a lack of brain activity, and I think in Kenya we are lagging behind in that definition. The other one is euthanasia, as my colleagues have said, is both passive and active. It is withholding intervention or having to actively stop intervention. Of course, it's easy to avoid than to stop. But also, I think I know we are products of our culture, And in many of our African societies, it is very hard to talk about death. I choose to give examples that are in my own life, because I'm not violating anybody's privacy. One of our friends had a spouse who was very sick and had terminal stages of cancer, and the doctor who was taking care of the spouse I knew her, and I'm the one who introduced them. So she called me one morning and says, your friends, we need to make a decision whether we'll take her into ICU or we'll just let her rest in the ward bed. That was the toughest decision that I've ever made, to go and talk to him, to talk to the spouse. It wasn't me making the decision, but just going to talk to him. And somehow the Lord gave me the words, and we had that conversation, and he chose to have her rest in the ward bed. And they had 3 days of saying goodbye and getting family to come and do it. But he did not want it made public, because if her parents got to know that he made that decision, it wasn't going to be pleasant. The other one that I want to mention is a decision that an auntie of mine made 2 years ago when she had cancer and she knew and she had exhausted all the options. She called her children and he says, look here, I do not want to die in hospital, I want to die at home. So please prepare yourselves. They found it very hard to honor that decision because she would get into emergencies and they would panic and they would take her into hospital. She would be stabilized and she came back home. So sometimes honoring those decisions is a bit tough. The last one that I want to make is my mother-in-law who lives with us, and she had a stroke 3 years ago and she ended up in ICU. And they said, no, she cannot go home. She needs to stay here. She stayed there for a month. And we said, no, we'll take her home. I said, you can't manage. We said, we'll try. It's 3 years and she's still there. And we are still trying. What I'm saying is that they are not easy decisions. We may not be able to discuss them with our loved ones because they may not be in that space. We may be called upon to make those decisions ourselves on their behalf. They are not easy decisions. They are tough. But I believe key to that is the issue of stewardship. That we are stewards. Oh, I'm a teacher, I can shout. That we are stewards of the resources that God has placed in our hands, and it is sinful to use these resources in a manner that does not please God. So I think that is, to me, a guiding principle. Is not easy. I also want to, I know you took us away from that other topic, but I also want to say the bottom line of many of these issues is not new. Remember when the Bible tells us in heaven, the devil said that he wanted to be like God. Remember when Adam and Eve in the Garden of Eden, they say they ate the fruit because the serpent told them that they would be like God. And the people who built the Tower of Babel wanted to get to God. So there is a desire in human beings to be like God and to live like God. And maybe we ought to interrogate our actions, whether that is what is driving us, for example, eugenics. But I also want to say that at the bottom line of this is, what do we believe happens after death? Because if we resolve this issue at a personal and spiritual level, then death will take a different format. It will have a different, we'll have a different thought. If, like Paul, we believe like to live is Christ and to die is gain, then it's neither here nor there whether you die today or tomorrow. But if we are not very clear in our minds, or we are not very clear about what will happen to us after we are dead, then we may have some of these challenges. So maybe if we can resolve that, it may help us.
Thank you, Prof. Actually, that is the take-home point on end-of-life issues. What is our perception of death? What's our understanding, Christian theology of death?
Not
That-
understanding, but our own
our
commitment. We may understand it out there,
Yes.
but we need to own it as persons.
Exactly, our theology around death. Thank you. We have some time, so panel, please just relax. I want to open up